Good afternoon, everyone. So I should be happy to seeing you all on this Sunday afternoon. And actually, you are all spending your valuable and precious time here on a Sunday afternoon. So let us try to make use of it the best. So today's webinar from Qurex would be on improving male sexual health. So this is basically to give an idea and to open up some questions which can be answered over the webinar. So I have planned this, especially this session, to understand what are the basics, how do we evaluate erectile dysfunction or sexual dysfunction, and how do we plan our treatment. So this is basically only the second part of the entire algorithm of treatment of all these problems. So we are not going to go into any details. We are just very superficial today. This will give a bird's eye view of all the things which we usually do in the andrology OPD and what is little different from all the other specialties which practice this problem. We have had initially some webinars on like erectile dysfunction itself under Qurex. So in this webinar, we are going to just discuss about these things. So the goals of this webinar would be mainly to identify like what are the goals, what do we all identify during this evaluation of the problem. So as in any problem, we identify the cause, we identify the severity, we identify the possible treatment options, like what are all the things which we can do. So during the evaluation, these things also come into the picture. And we also formulate the plan and understand the implications of the disease and the implications of the treatment which we are giving. So these are the basic things which we usually want to do at the end of this evaluation of the problem. So what are the important aspects of male sexual health? So we should all understand that sexual health is a marker of overall health and general well-being. It includes a lot of components. It is not only the erectile part, the ejaculatory part, and the satisfaction thing. It is also related to the general health, the overall health, the interest, the relationship between the partners, and so on and so forth. So these are so many things which we actually do. But this is only a small thing. It's a small subset of the overall health. So male sexual health means all the things. The mind has to be strong, the body has to be strong, the partners have to be like they have to be in sync. There are so many other things which we also see. Today, what we are going to focus in our platform in this webinar is today to understand the basics of evaluation. Maybe regarding the treatment, it will be in some other session. So what we are going to do in male sexual health, this 5 things this is only a guiding factor. So our overall algorithm depends upon these 5 things, but this is not restricted to only these 5 things. So basic thing, when we take the history, we ask for an important thing like what is your erection? How much hardness do you get? So this is a thing which we lot of times have difficulty in communication. The patients may not understand what exactly we are asking, or we don't understand what exactly the patient is communicating. We also need this to be documented somewhere so that we can understand whether our treatment is making an impact, or as a disease process, the things are reducing, like the overall erectile function is reducing. Is there really a improvement? These are the things which we can understand. So for that, we try to objectivize a subjective symptom. So we see here that erectile function, what one person claims to be a hard erection, maybe the partner is not happy with that, and vice versa. So we need to have some objective thing. We have to base our discussions, our treatment, and the outcomes based on these parameters. So that is what we do in andrology. We have objective assessment on history. So there are a lot of questionnaires which are available, and the commonest thing is the SHIM or the IAEF score, that is a sexual health inventory for men. We do try to utilize this questionnaire in most of our patients to help us understand what is the real problem and what is the grade of the problem. So as I told in our initial slide also, one of the important goals of the evaluation is to assess the severity. So out of this question, based on the answers which is marked by the patient, we can grade the severity of the ED from no to severe. And this gives us an idea as to whether we progress from severe to moderate or moderate to mild during the treatment, or we still remain in severe, which means that the problem is either severe or the problem has not been identified properly. But we find this to be cumbersome and difficult at times, especially in a busy clinic. So in Qurex, when we take a lot of time with the patients on an online consultation, we have dedicated staff and people doing that. That's a different situation. But in my clinic, where we practice andrology along with other things like erectile dysfunction, infertility, testosterone, there are so many things which we practice. We do utilize a shorter version, which is the erection hardness score. So I've written the erection hardness score here, where we have grade 1 to 4, where based on the amount of erection, what length, whether the length is increasing, whether the hardness increases, whether is it enough for penetration. This is what we have, and this is the so this is a video. So since the pointer is on, just a minute. Okay. So this video is not playing, it's okay. So we have the erection hardness score based on which the patient can see, present, feel, and tell us like what is the erection and how much is the improvement with the medicines, etc. And we can ask the partner what is the real erection which the husband is getting. So based on that, we have a clarification and confirmation that okay, things are fine or things are not okay, whether the partners are in sync, all those things we understand. Okay. So the next thing would be, yeah, this is the video. So this clearly gives us how much hardness is the patient is experiencing, so that with this we can understand what is happening. Yeah. So coming on to the next thing, when we evaluate a patient, what is the basic? So what is the basis on which we do these things? For this, we need to understand how an erection happens and how an erection comes to a completion. So the mind thinks. So the mind has to think, or it has to get a sexual thought, see a partner, get aroused. So this is the first step. Then the mind sends a signal to the spinal cord, and the nerve transmits the signal to the penis. This nerve ending secrete a chemical which is nitric oxide. This chemical induces a cascade. There are multiple things which happen. So at the molecular level, things are happening. Calcium, there are so many things which are involved in the mechanism. After all these things happen, this chemical induces a blood flow in the penis, and the penis starts getting bigger. Then the penis becomes erect. Here, what happened? This is the all these things is the initiation of the erection, and the next step comes the maintenance of the erection. So the blood has to be held in the corpora cavernosa, which I will tell you in the next slide. So the corpora cavernosa are two cylinder rod-like things in which the blood has to stay. And after a period of the erection has stayed and the repeated stimulation has happened in the glands, then ejaculation happens. And once this happens, the blood goes back and the penis becomes soft. So these are the basic steps which happen. And these are the things which we also focus when we are trying to evaluate an erectile dysfunction. So there are so many at these so many levels we can have problems which is causing the issue. So this is the basic anatomy of the penis, where we have two structures. One is the corpus cavernosum and one is the urinary passage. So in the corpus cavernosum, blood fills and the penis becomes erect. So the causes may be something in the mind which can cause a problem, the hormones which are involved in these mechanisms, the blood vessel factors, and the nervous system, as I told. So these are the four major groups in which erectile dysfunction can happen. And we are always trying to identify, is it a single factor or a multifactorial, which is more, how do we proceed? What will be the final treatment and how do we go about managing this patient or this couple? So this is in essence, this slide is in essence the entire algorithm of evaluation of the erectile problems. So we have two major groups. One is the psychogenic and second is the organic. So psychogenic erectile dysfunction is, actually speaking, there is nothing wrong in the body. It is only related to the factors which I mentioned. It may be a blood vessel problem, which is vasculogenic. It may be nerve related problem, neurogenic. It may be a hormone related problem, which is either of the sugar or testosterone levels, which we all know. Or it can be something in the penis itself, which is cavernogenic. Whenever there is an organic problem, it is one of these four. Usually it's a gradual onset. That is, the patient doesn't develop symptom in 10 days, 15 days, 20 days. So whenever it is sudden onset, it is always more likely psychogenic. And in organic, it is all attempts. Every time the patient faces a problem. Whereas in psychogenic, there are times where the patient develops a very good erection and sometimes there is no erection. And in psychogenic, what we as like andrologist or urologist, what we practice is early morning erections. So they are supposed to be maintained in or psychogenic ED, and in organic ED it is lost. But when the mind is so confused or is it very affected because of various problems in a severe form of psychogenic ED, which is actually based on history and examination, very difficult to differentiate between a severe psychogenic erectile dysfunction and an organic erectile dysfunction. Again, in the severe psychogenic erectile dysfunction, it behaves like an organic ED and the early morning erections are not there. So it is often difficult to dichotomize ED into psychogenic and organic categories. However, our basic idea is to see where the patient is fitting in and how do we plan our treatment. This is where we have this assessment and evaluation of having a counselor or a psychotherapist in the team to identify what is happening in the mind. And we also have tests which to identify what is happening in the body. And this is where, on the basis where we do the treatment. So the lab evaluation is mainly involved in identifying the cause, as I mentioned, a sugar profile, a lipid profile, and testosterone. These are the three basic tests which we do. We also add creatinine, thyroid. There are basic tests which can be done. But the sugar, the lipids, and the testosterone, this is very important. So this involves the triglycerides, cholesterols, the LDL and the HDL, etc. are involved here. These are the things which are more specific. In specific and certain circumstances, we use them. So again, as I told this slide, where we see that the mind thinks, it sends a signal, all those things. So we can see that in the mind, there can be a situational problem, hormonal issues, or stress. Whereas from the mind till the reaching the penis, it may be a nerve related issue where the nerve is not transmitting the signal properly, or it can be a penis related where it can be in the structure of the penis or in the blood flow which is reaching the penis. So it can be a penis or a blood flow related problem where there is a chemical. So the chemical is not getting released, or once the chemical is released, there is no enough space in the blood flow, like the blood flow is not happening properly. These are the reasons why the erection is not happening. And of course, for these things, there are other things which can be a reason. So now going on to how do we manage these patients. So the first thing is the basic background check. So we take a detailed medical history and a detailed sexual history. So we ask for specific histories like diabetes, hypertension, heart disease, stroke, and peripheral vascular disease. These are all related to the blood vessel. So we also want to see if there is any other blood vessel system which is involved. If a patient has already had a heart attack or already is on medicines for the heart symptoms, like say they are in borderline cardiac disease, etc., then we also understand the basics of our disease there itself. So now we know that there is a possible blood flow problem. When we go to a detailed sexual history, we try to see whether it is an initiation problem, maintenance problem, is it a mind-related issue, all those things we want. So we ask the patient to rate the confidence of getting and keeping an erection. That is where we use the questionnaires and the model which I showed. Is the penis firm enough? Again, we use the two questionnaires. Is there an ability to maintain the erection? Satisfaction? Is there a morning erection? What is the level of sexual desire? Has there any surgery or treatment which has damaged the nerves or the blood vessels? Or is there any drug abuse, drinking, smoking, etc.? So these are, in a nutshell, the most important histories which we elicit for our patients. And basic examination involves mental health and physical exam. So we have trained assessors or counselors who take a detailed history. We have specific questions which we ask to the patient and the couple. We understand what is the stress level, what really is happening to the patient because of the disease, and because of the patient, what is happening to the disease as well. So we try to identify what is the emotional status of the patient. Is there a good intimacy between the partners and all those things? And we do a physical exam, which involves the other organ systems like the heart and the nerve, etc. If there is a reduced sensitivity, we look for a nervous system issue, any low back pain. Is there any reduced sensations in and around that area? Is it related to the spinal cord problem, etc.? We also examine the penis in detail. We see for the foreskin issues. We see if there is any balanopositis, that is where the head of the penis and the skin of the penis may be a problem. Again, can indicate sugar. Is there any bend of the penis? Is there a plaque? Is there a hard area in the penis which is suggestive of Peyronie's disease? We also do blood tests to uncover the etiology. As I told, maybe a kidney issue, thyroid issue, heart issue, and hormonal problem. So these two slides are very important. We do a basic history, comorbidity assessment, medicines, and also the basic mental health, physical health, and physical exam, and the blood test. So these are the most important things which will guide us to the understanding of the problem. What could be the most common reason? Hormones, as I mentioned, can be sugars, testosterone, most basic hormones. I mean, this is not a hormone, but HbA1c is related to the insulin and the glucagon. So I have put it here because that is the most common hormone related. So diabetes is the most common hormone related problem which can lead to ED, even more than testosterone. Prolactin and estradiol are specifics in certain patients. So traditionally, after this, the doctors and in most places, they practice to do a penile Doppler, where they put an injection into this area. So this is what I was mentioning. So this is actually upside down. So this is the area where the blood flow happens, and this is the area where the urine flow happens. So there are two structures called the corpora cavernosa, where the blood gets filled and it becomes big. This black line is the tunica, that is supposed to be the structure like a rubber band which holds the blood there. And this is the urethral passage. So when we put an injection, we measure the flow, we see what is the velocity of flow in this by using a Doppler, which is this type of probe which is used. So this is basically what is done in the clinics. We also have something called a nocturnal penile tumescence rigidity assessment, which is not a very practical test and a very highly available or used test, because we can understand whatever this test gives, we can understand by other tests and history and examination as well. So this is, even though not routinely practiced, this is also a test which is done in the modern days. So now, once we see a patient, so taken the history, we've done the examination, now we are confused as to which way to go. Should we do a NPTR? Should we do a Doppler? So what should we do? Start medicines, do hormones? What should we do? So this is where everybody get confused. This is where we try to follow the pathway of office sildenafil test whenever the patient is available for a physical consultation. So we give a drug which improves the blood flow. We assess the erection after 1 hour with giving a privacy and self-stimulation. We explain the patient this test. We give the medicine and we ask the patient to show us an erection. So this is a good tool to differentiate between psychogenic and organic causes, because in a patient who has more of a mind-related issue, this test is usually 100% good. That means the erection is good and we are able to understand that it is probably a mild issue, or is it more in the mind. So these are the most important things which we understand with this test. And this is a roadmap to the further investigation. So once the office sildenafil test is good, we conclude that this patient will do on medical therapy, psychotherapy, and we have a good chance that we can stop the medicines later. Going on to the other advantages, it assesses the quality of erection. Once the patient sees an erection, it is very comfortable for the patient. He gets back the confidence which he has lost. Since we are going to use the same medicines in the treatment, we also understand what is the side effect. And the patient also now comes to know, as I mentioned in the first slide. So 1 hour after dose, we have to do the test. We have to stagger the dose with the food. These are the instructions which are given. Patient immediately gets to understand how to take the drug. So these are the most important things. And along with these things, we give some advice when the patient leaves the consultation room after completing the tests. The next is an injection test, which is done by a healthcare professional, specifically a urologist or sometimes a radiologist, who injects a drug into the tissue, which I mentioned. This is the blood flow area and this is the urinary passage. So we insert the needle here and we inject a calculated dose of the drug, which is either a bimix or a trimix. I will come to that. So this is the penis like this, and we inject the drug here. So once we injected, in the injection test, this is the injection which is used to assess the blood flow. So after this injection, either we assess the clinical erection, so how hard it is. We compare it with the whatever scale I mentioned, the erection hardness score, which the video was played, or we measure the blood flow. So what we do in the andrology practice is, more than assessing the velocity of the flow by using a machine, we assess the clinical erection. We ask the patient, what is your basic erection? Is it better than this? What is the dose which is required to bring out this erection? And this diagnostic injection is very specifically useful in a patient with the severe organic disease, diabetes, vascular disease, and where a patient has failed his office sildenafil test. We also have some other utility, like whenever there is a bend, we use this test to understand how much curvature is there and what is it doing to the patient and how to modify it. What is the basic reason why this test works better than the tablet test is because this bypasses the hormonal and neurological influences the patient has in getting an erection. So once this test is working, with a low dose, if it is working, it probably means that there is a etiology, that is possibly a psychogenic or a mild organic disease. And if a patient has a neurological problem, if this test works, again, it means that the blood vessels are intact, but the nerve, there is a problem in the nerve. So we are able to understand so many things with these two tests. And this is what we specifically practice in our OPD. And this is what we want to do whenever a patient is getting confused as to why the medicine is not working, why this problem has happened to him. So we have a bimix, which is a combination of two drugs. We use a papaverine, which is a single drug. And this is the syringe with the smallest possible needle of around 31 gauge size, which is a very small needle and it hardly paints. And we have trimix, which is a bimix with alprostadil. So many people watching this webinar would know about Caverject, which is available in the United States, where alprostadil is being used there. This drug is not specifically marketed in India as Caverject. We don't have a commercial preparation where we have a fixed dose which can be used. Instead, in the clinics, we prepare this injection, and this bimix is more popular in India. This combination, papaverine and chlorpromazine, is more popular in India and is available in very select centers, around 10 to 15 centers across the country, who practice bimix injections, and we are honored to be one of them. The next comes the importance of testosterone. The primary male sex hormone, which regulates the sex drive, is responsible for the growth and development of the testis and to maintain the prostate health. So what does testosterone do in erectile function is, it contributes to erectile function by stimulating the nitric oxide production, which is the chemical which is secreted by the nerve. So this is essential for the blood flow in the penis. So as I mentioned, testosterone acts mainly at two levels. One is to give the interest. Second is to prepare the surface, like give the platform for the blood to flow. And also by helping the nitric oxide, it also helps in improving the blood flow. So the effect of testosterone is on bone, muscle, skin, brain, bone marrow. But on the sex organ, it is mainly involved in the erectile function and the blood flow mechanism. So what does diabetes cause to us? So diabetes causes increased blood sugar levels. So this blood sugar level actually damages the vessels, the nerves, and that is why the blood flow reduces. So we also see that the prevalence of erectile dysfunction is 3.5 times more in men with diabetes than in those without diabetes. So diabetes is an important risk factor for ED. Similarly, we detect diabetes in most of our patients who come with erectile dysfunction. If they are approaching to us for the first time with no tests and directly they came to meet the andrologist with erectile dysfunction, we do a HbA1c test and it is mostly positive. Most of the times this test is positive, or it is in the range of pre-diabetes where the HbA1c is around 6 to 6.5. This only means that diabetes can affect the blood vessels, and this blood vessel problem can manifest even before the other effects of diabetes are set in. And erectile dysfunction is an important marker of diabetes and heart disease. And whenever you have an erectile problem, a sugar check is very important. And one more thing is, whenever there is a problem in the head of the penis, like a baronoprostatitis, again, there can be an indication of diabetes. If you see this problem, again, get a sugar test done and check with the doctor. So risk factors of diabetes are sedentary lifestyle, overweight, obesity, taking more calories, and genetic predisposition. And half of the men with type 2 diabetes, if they don't control their sugars, this problem will worsen and they will result in erectile dysfunction. And this can also damage the blood vessels and nerves, and thereby the problem happens. So this is again how the diabetes causes these problems. So diabetes can cause blood vessel issue, nerve related issue, hormonal problem, and a structural change in the penis, which is more likely the tissue which itself becomes hard and fibrotic, or it can lead to Peyronie's disease, which can lead to curvature and the formation of a plaque-like thing. So cardiac health and erectile dysfunction. We all know that with age, the blood vessels become small. That is because of atherosclerosis. As we age, there is fat deposition, cholesterol deposition inside the circumference of the blood vessel. So we have to understand why erectile dysfunction is called a marker of heart disease, because pineal artery is supposed to be the smallest in all these four things. And 2 mm, 4 mm, 6 mm, 8 mm is the usual size which we tell for the patients. So for erectile dysfunction in the penis, it is 2 mm. For the heart, it is around 4 mm size of the blood vessel. For the carotid arteries, which we tell, it is around 6 to 8 mm, 6 to 7 mm, and it's more than around 6 to 8 mm for the blood vessels in the lower limbs. So we know that if this is going to get blocked, this has to get blocked before. So whatever, if erectile dysfunction happens, you are at a risk of all these problems, and this is the best time for you to identify the problem and do some corrective action so that these three things don't get blocked. So erectile dysfunction is an important indication that there may be a heart disease which has to be looked into, especially when the patient doesn't have a good report on the sildenafil test and the injection test. We are very sure that we have to check the heart and also the blood vessels going to the brain in certain patients. So risk factors of erectile dysfunction can be balance between the body and the mind. So when the individual is very stressed, we don't know what is happening. If he is more stressed in the workplace, if there is a lot of financial stress, emotional stress, partner related stress, there are so many reasons in the mind which can lead to erectile dysfunction with the body being normal, or vice versa. The mind is completely okay, but there is a problem in the body. So both the things we have to match. So even the male gender, the age, all these things are possible etiologies for erectile dysfunction. Smoking, hypertension, stress, cholesterol levels, lack of exercise, diabetes and obesity are the most important risk factors. Age, diabetes, hypertension, and smoking. So most common 4 things which we have to remember. Again, the neurotransmitters. Now there is more and more understanding about the neurotransmitters in the brain, which can lead to a issue in the mind, which can lead to erectile dysfunction. Healthy diet, sleep, and physical activity is the medicine for these problems. For erectile dysfunction also, these are the treatment options. So at the end, we now understand that in andrology, we evaluate erectile dysfunction more effectively. So we use the questionnaires, we use the scores. We also ask for specific questions like libido, partner preference, frequency of intercourse, etc. in the history. Examination, we have specifics like we do the penile length, the penis as a whole. Is there any hard area like a Peyronie's disease? We also do the sildenafil test with or without the injection test to guide us to understand the blood flow. Specific investigations of blood like sugar, cholesterol, testosterone, and lipids. Cardiac assessment is very important whenever there is a risk factor like diabetes is already there. Patient is not getting good improvement of medical therapy, and smoking is there. All those things, importantly, they imply that evaluation of the heart is important. We also have a shared decision making with the couple to understand the couples, like the wife's side, female partner interview, what is the expectation, and discuss the options with the husband and wife or the partners to understand the treatment options. So I think we have had a 30-minute discussion about the basics of erectile dysfunction and how do we evaluate these patients. We are now open to have some questions to understand your queries. This is a small step, but it is a giant leap for the individual and the couple so that they have a good sexual health and overall health. Thank you for a patient listening.
So now you can ask your questions. I'll just share another screen and then you can put your questions there. We have a link in the chat box where you can put all your questions and Dr. Karthikeyan will answer to them.
Okay. So the first question, after receiving the injection of the penis, does it still maintain its ability to become erect despite the discomfort? This procedure seems indefinite. So this injection test is not a very, it means that you don't have to worry about it too much. It's a small test, like whatever test you undergo, we take blood, all those things. This is like something like similar thing. I mentioned the size of the needle, which is very, very, very thin. Second thing is we at our center, we use a local anesthetic to actually numb your penis during the test. This test is done only to only to check whether the blood flow is happening. So once we give the injection, the blood flow happens. We assess the quality of the erection. And once the patient ejaculates, the erection drops, or we give a downer injection, which reduces the blood flow and the penis becomes soft. So during the slide also I mentioned, like there is a normal physiology where the blood first enters, ejaculation happens, and the blood flow goes out. That's the same thing which happens in the test. Once the test is completed, if the penis doesn't become soft, we make the penis soft by 1 or 2 small injections. This is a completely safe procedure. We do at least 15 procedures in our OPD every day, and hardly a patient has a problem. Since this is done under a local anesthetic agent, there is no problem or intimidation about this. Can we go to the previous screen? Yeah, okay, you continue. So to improve the erections, you don't have to get the most important problem which we are facing nowadays is the patients usually try to Google and try to understand the problem without having a clear answer. Sometimes they get confused and they then come to us asking for, is this a psychogenic ED? Is this a or blood flow related problem? As a patient who is having this problem, we appreciate the quest for the knowledge which you have. But once you have reached a doctor, the treatment has started. It's very important to keep up with the treatment rather than questioning or getting confused with yourself what is happening. So whether it is a psychogenic ED or an organic ED is for the doctor to make out so that we give our treatment and we know what to expect. Other than that, in a psychogenic ED, actually, if the cause is identified with good counseling, psychotherapy, we can bring you back. We can bring you out of the problem, even without the use of a medicine like tadalafil. However, the dosage of the medicine is very mild, a daily medicine or a SOS medicine based on the condition, and it's a short course, around 2 to 3 months. If you are responding well to the psychotherapy, then the medicines can be stopped even very quickly, like 1 to 2 months also we can stop. We also try in some patients who are really understanding and concerning. We usually even avoid the medicines for blood flow. We try to calm their mind by psychotherapy, etc. We give some specific medicines to calm you, and we see if you really require the PDFA inhibitors, which is tadalafil. Again, if I smoke 2 to 3 cigarettes a day, can I still get ED? The number of cigarettes, even though it matters, if you smoke more, you get an ED. There are some people who are prone or destined to develop ED even with 1 or 2 cigarettes. So we really don't know which patient will develop ED at 2 to 3 cigarettes or 20 to 30. But it is best to keep these things to a minimum. If I have triglycerides slightly higher, can it affect my erections? A short period of time where the triglycerides is high, it may not affect your erections, but on the long term, yes. So this also means that once you get ED with high triglycerides, you have to protect your heart from this triglyceride. So you have to do medicines, identify the cause. Like if there is a triglyceride, sometimes it can be a triglyceride problem itself, which requires specific medical therapy. Other than that, diet, exercise, following a dietitian's advice can help you. Taking one take tadalafil 5 mg for a couple of years. See, the long-term safety and the efficacy of tadalafil has been proven. However, our idea is not to give you tadalafil for a long duration of time. We specifically want to give this medicine for 3 to 6 months and see how much improvement it is causing. So disc prolapse or spondylosis can cause ED in some patients. So even though we see that the disc prolapse is at a higher level, there are some patients who come with a neurogenic ED, especially after the treatment. At that time, we understand this with the discussion with the neurosurgeon or the spine surgeon, what level of the spine is affected and what is the effect of that on our nerves which come from the spinal cord to treat ED. This is again more likely to be a mental related issue, like the mind related issue, because you're going through some disease, you're undergoing treatment at the time, maybe you're not in the correct frame of mind. There may be some weight gain, etc., because of which this problem can happen. It is not only neurological, and usually medicines work well. At this point, our injection test works where we able to differentiate whether it's a vascular cause, that is a mind or a blood flow problem or a nerve related problem, which can help us in treating you. The penis in normal positions feels very low. So whenever you're constantly thinking about something else, the basal blood flow may be little less and you may feel that the penis is like very small. But once you start getting the feeling, once you start exercising, the blood flow improves and you feel better. The tests which you can do right away are mainly the HbA1c, that is the 3-month average sugar test, testosterone and lipids. And if you're going for a basic health checkup, you can always do it because it also includes thyroid, creatinine, and also an ECG. So these are also important things, the second round test. So you can go for a basic master health checkup, which involves the basic tests like creatinine, sugar, uh, lipids, etc. However, testosterone is not a part of that. And we also don't rely upon testosterone as a first line investigation unless you are very particular about it because of the advent of the digital media. patients now get the testosterone and then come to us. So, but what we think is testosterone is, even though it's a first line test according to recommendations, that is not a first test which I do. I usually ask for a glycosylated hemoglobin HbA1c, which is the first test. Yes, diabetes may be a cause of ED, but again, is diabetes the only reason in your case? Maybe we have to evaluate and find out. We see that even men with a good, like a very uncontrolled diabetes, still to have erectile dysfunction. So it is not only the sugar and ED. This is one of the important reasons where you give up an ED. So the Qurex team will contact all of you and then tell you how to consult us. There is as such no side effect to masturbation. Masturbation cannot cause ED. It is like only a myth that masturbation can cause ED. I think we have answered all these questions.
Any more questions, guys? So there's a question. Took Sheilajit no help in ED. Don't want allopathy. Too much side effects. What to do? Could you
Yeah.
please answer this?
Yes. So it's a very, very important situation which we face in our OPD. We are also, as I told you, we are not only of the impression that we should give medicines to treat you. We can take a detailed history where we understand your mind and the body. We do the tests, we understand like whether really you would benefit without drugs, because you told that medicine is having side effects and Shilajit is not working. So if these things are not working, we have to identify whether you will benefit from medical therapy. If you have a side effects, then we do psychotherapy. With the erection assessment, we understand how much blood flow is happening. If there is a patient who is not developing good blood flow in the tests, that means that you probably need something else. So in these situations, we have additional therapies like self-injections. So somebody was asking like to do the test also, it's intimidating. But you have to understand that we do this self-injections as a treatment option. So there again, if you have side effects with the tablets, you can take self-injections. With therapy, you can improve. If you don't improve with these things, we have experimental options like platelet-rich plasma and shockwave therapy, or we do have an implant option. So these are all the things which you have to keep in mind. You don't think if I took Shilajit, there is no help, I don't want allopathy. Is there no other way? You can go for psychotherapy. You can go for testing to understand how severe is the problem. And really at all, if the Shilajit is not working, arginine is not working, why it is not improving? So these are the things which we can look into. How to intercourse for a long time is a very common question in the OPD. Here again, the reason to do this could be to satisfy the partner, but again with psychotherapy, you'll understand that it is not always doing a intercourse for a long time alone is essential to satisfy the partner. For you to improve your intercourse time, you should maintain an erection, which comes with physical activity and weight reduction and some medicines. And to improve the timing, again, it is psychotherapy and basic pelvic floor exercises which will help you. First time sex is always short because both of you don't know how to do it. As you go in your journey, you may do better. If you are not able to understand it, then you always have experts to help you. So somebody who has asked about imagination, sex, etc. This is a little deeper topic where we have to understand your health, mental health, psychological health, and physical health, which can be a reason for this problem. But you may do well with actually a psychotherapy. I work out every day, take protein and creatinine. Suddenly, I have seen low sex drive. So, as I mentioned in the initial part of the presentation, somebody who has something sudden is usually having something more in the mind than in the body. So, again, a detailed talking with you can actually uncover the problem. So, at 23, if you're having this problem, it is less likely to have a problem in the body. And it may be less likely that you are having a problem in the mind also. At this stage of life, you are more concerned about the symptom. That is what I can understand. So again, as I told you, an assessment of the symptoms and the assessment of the blood flow will help you because we get to understand what is exactly going on inside. And based on that, if your tests are good, then we can reassure you, we can talk to you, we can uncover your like what is the problem in the mind, why are you thinking like that, or why are you having a manifestation like that, and we can treat you. So sex is physical, why therapy is required. Therapy is done whenever the physical thing is not happening properly. So if somebody has a problem, then only they come to us. So at that time, we have to identify what is the problem and what is the treatment. So therapy means it is to clear the mind of confusions, and medicines are more important for improving the blood flow. Diet plays a very important role. So the proper diet is responsible for a good blood flow, because if you take more calories, junk food, etc., obesity can happen, may predispose to diabetes, etc. And that is the way how diet works. With modern medicine, even though I am not the right person to talk about depression, in modern medicine, we do understand the relationship of neurotransmitters and depression. So a mental health professional will be the best person to identify the cause. And if it is a mild form, again, more of therapy works rather than medicines. And once you come out of your depression, probably your erection also improves. So if you require medicine, then our psychiatrists can always help you to take some medicine and understand your problem, do therapy, and all these things improve.